Good afternoon, and first batter up. My name is Dr. Aaron Kim. I'm a podiatrist at MK Orthopedics, and today I'll be talking about ankle pain. Just to let you guys know that we're official team physicians for Joliet Slammers, Bolingbrook High School, Plainfield High School, and also Providence High School. Basically, when the sports teams actually start, see a lot of students from Lincoln Way and also Lockport High School too. The reason why I'm actually mentioning this is that it's that time of the year where people get actually a little busy, get a little bit more active, so there's a lot of injuries that has to do with foot and ankle pain. So just to let you guys know that there's about 50 million people actually coming into the emergency room for some sort of pain, and usually 80 to 90% of them are actually has to do with sprains, strains, and contusions. So ankle pain is increasingly common, especially in sports-related injury, as we cover a lot of these kids playing football and basketball and track, soccer. Work-related injury too. The physicians in our facility are all certified independent medical examinators, so we do tend to see a lot of work-related injury, and also arthritis too, just your normal wear and tear, which we will go further into details. Just a quick overview. Unique design of the ankle makes it a very stable joint. As you can tell here, there's a tibia, which is your shin bone, and fibula, which is the skinny bone out of the two, and also the talus, which is a portion of your foot, comprises the ankle joint itself. And when you're walking, you're putting about 1.5 times your body weight, which is a lot of weight. On top of that, when you're running, you're putting about 7 to 8 times your body weight, which is a lot of weight. So just imagine if you're gaining a pound or two, you're putting a lot of pressure on that ankle joint on a daily basis. So just a quick overview on the ankle ligaments and tendons. The reason why I'm actually showing you this is not to quiz you at the end of the presentation, is to show you guys that there's a lot of tendons and ligaments involved that makes the ankle as a whole joint. So it's not only the tibia, fibula, and the talus that makes the ankle joint, it's also these other ligaments and tendons that are important, making this structure a whole joint. So sports-related injury, I don't know if you guys know, this is Kobe Bryant, basically ruptured his Achilles tendon last season. And this season he came back after long months of hard work and physical therapy. And unfortunately, he still had to shut down half portion of the season. A lot of the things that I see normally, like I said, I treat a lot of high school students who are going into Division I schools, to a lot of varsity football players, to basketball players. There's a lot of fatigue and overuse nowadays, especially with around the year training, with a lot of kids playing soccer, indoor soccer, football, weightlifting, basketball, around the year, because a lot of parents are, not only are they pushing, if you're actually good at what you do, a lot of parents are hoping that these kids actually get a good amount of scholarship going into college as well. So there's a lot of overuse, fatigue, and also a lot of kids won't try to complain as much, even though they're hurt. So half the time they're actually playing injured. It's one of the reasons why I see a lot of ankle injury, ankle pain secondary to sports-related injury. And second of all, work-related injury, there's a lot of factories setting out in Bolingbrook and also Joliet and also in the Lennox area where I see a lot of work-related injury. It's because of the work environment, the terrain itself, going uphill, downhill, working on a bunch of pebbles and rocks, uneven surfaces, and also heavy machineries too. I can't count the number of x-rays I had to take because a lot of patients got ran over by heavy machinery. So, and also dangerous tools too. There's some laceration, open wounds that can happen near the ankle joint too, sometimes causing tendon injuries as well. And arthritis, weakness, instability, I mean, this is a normal aging process, but if you don't treat your previous injury, the arthritis do tend to set in a little quicker, so that's something that you guys should look into. So the clinical exam findings that I see, a lot of these guys are coming 2 different ways. Number one, if the pain is severe enough, they'll go to the emergency room and get consulted, so they'll see me in about 2 to 3 days after. But there are some ones like me who would actually try to tough it out, does not want to see a doctor, so they wait about a week out, and then they realize that about a week out it has not gotten any better and pain is severely worse. So they come to see you as a outpatient and clinical setting. So some of the clinical findings that I see here is redness, swelling, continued throbbing, bruising, limping, and instability. And I just want to tell you guys the importance of the imaging studies. All the doctors wishes that they had an x-ray vision, but unfortunately we don't. So obviously you want to start out with an x-ray just to make sure that there's no dislocation, subluxation, any fracture nearby. But unfortunately, x-ray does not allow you to see the soft tissue structures, meaning that any tissue damage, including tendons, ligaments, you cannot see with the x-ray. So what you want to do is a lot of doctors actually have what's called an ultrasound in their clinical setting. It's a live tool, meaning that they can turn it on, review what they find with you right in front of you. But unfortunately, sometimes ultrasound itself may not show everything. So sometimes, if necessary, we have to get a CT or an MRI to further evaluate your underlying bone and soft tissue damages. So this is just an example of an x-ray film. On your left side, it's a normal ankle joint. As you can see here, there's a tibia, fibula, and also the talus. As you can see, the ankle joint here is well aligned. Nothing's broken. Obviously on the left side, there's a red arrow showing two different places of fracture here. This is a high fibula fracture, and this is what's considered a medial malleolar fracture. This is unstable, and it's something that needs to be surgically repaired. So without the x-ray, just looking at you clinically, we can't really further assess you. So this is one of the important reasons why we have to get further imaging studies to further evaluate you. Sometimes, unfortunately, x-ray cannot see everything, just like I told you. So if it's a soft tissue damage, this is actually one of my patients of mine who actually tore his Achilles tendon. This is a gentleman, I see a lot of gentlemen who's dormant over the winter time, just like myself. And then when spring hits, they get excited to play softball. And of course, it's not just softball, it's beer league softball too. So everybody who's in a softball team, they're overweight, they have not been stretching, they've just been dormant throughout the winter season. And when they get excited going out to play softball, they get a nice hit. As they're rounding first base, they tell me that, Doc, I just felt like I got hit by a sniper. I don't know what just happened. That's when they actually snapped their Achilles tendon in half. So this is one of the sports-related injury that may lead to a tendon injury around your ankle joint. And it's not something that you can assess with just an x-ray itself. So this is one of the reasons why we go a little bit further and get the MRI imaging studies. So of course, when you guys all come into my practice, what I try to start out with, obviously, the conservative care. If I don't have to cut you open and make another incision to repair you, why go there? So we try everything conservative initially by using pain medication, injection therapies, swelling control, shoe modification, ankle braces to orthotics, hard cast, walking, boot, and physical therapy. But unfortunately, sometimes, I'd probably say about 60 to 70% of the time, conservative care is the right thing to do. But if there's a structural defect going on, including a tendon rupture, a tendon tear, a fracture that needs a surgical care, it's a structural defect. So surgery is necessary at times, not all the time, but at times. So what I'm going to focus on right now is just to make sure that we go through some of the symptoms that you get with the ankle pain and tell you what kind of surgeries that we will be able to do. This is what's called ankle synovitis. This nasty red-looking stuff that you see here, it should be nice and white and normal. So what happens is that synovial membrane is basically a very important structure that protects the joint space. Just think of it as a squeaky door. And what do you want to do to a squeaky door? And put a little 10 WD-40, right? To allow it to kind of have a less squeaky noise and also allow the hinge to work a little better. Same thing, if the synovial membrane itself gets inflamed and gets disturbed, it gets angry. And every time you walk, it feels like you're catching something deep inside your ankle. You can't really explain it because it doesn't happen all the time, but when it does, it really does hurt. Obviously, you want to start out with conservative therapy as we talked about. Injections, casting, physical therapy. If none of that really works out, then the next option will be a surgical intervention to perform what's called an ankle arthroscopy. What ankle arthroscopy is a very minimally invasive surgery. There'll be two portals, one at the inside portion of your ankle, one at the outside portion of your ankle. What I normally tell the patient is that in one portal, you'll go in with a camera, small little camera. In the other portal, you'll be going in with basically a vacuum cleaner. So you have a lot of gunk inside your ankle joints that needs to be cleaned up. It is very minimally invasive. No surgical scars involved because it's less than a 7-meter incision. And quick recovery time, and it is both diagnostic and therapeutic. Meaning I can go in there with the camera and see how your ankle joint is doing overall. If it's looking fine, we're looking good. But if I go in there and find something wrong, I could use different instrumentations that are minimally invasive for me to actually clean the ankle joint area up. I've had patients go back to work as soon as 2 weeks when the sutures are out, and they're happy and they're going back to regular work, no problem. Sometimes ankle joint arthroscopy could be used with other tendon treatment as well, which I'll talk about a little bit later. Ankle fracture, pretty obvious, right? You sprain your ankle bad enough to a point where the bone breaks in half. So basically, if you see this fracture here, this is basically called a fibula, and you see a little clear break. So it could be due to an ankle sprain, fall from a height, if somebody accidentally kicks you. Or I recently had a pediatric patient that I just saw about a couple hours ago, chasing her friend in the gym class. She happened to have a ankle fracture, and unfortunately for her, she's still growing. She's still 11 years old. So unlike all of us in this room, she's still growing, and she has a growth plate that's still open. So for kids, it's just a different treatment modalities for them. But if it's a fibula that's broke, we call that lateral malleolar fracture. If it's a tibia, your shin bone, it's called a medial malleolar fracture. And surgical intervention will all depend on the extent of it, meaning if there's a fracture here, and if your bone's over here, obviously there's a huge displacement, right? But if it's close enough, and it could kind of repair itself by your own body's ways, then we can cast it and continue with the conservative care. So this is an x-ray of actual patient of mine. As you can see here, this is my instrumentation showing where exactly the fracture is. I don't know if you can kind of see it. You can see this white line coming down to the joint, and this is a tougher one to see. There is a fracture in the bottom portion of the fibula that's comminuted, meaning that it's in multiple pieces. So what we decided to do was we talked to her. She was walking out of the garage, gardening, and she actually stepped wrong, and she thought it was just a sprain. She was a tough lady, came back to see me about a week out, found out she had a pretty severe ankle fracture. So we talked about conservative care versus surgical options, and it was determined that she was young. She was in her mid-30s. She's very active, loves doing Zumba, so she wants to get back as soon as possible. So if you wait around and not do the surgical intervention at the time being, you bad luck down the road and have what's called a non-union, meaning that the bones just don't want to unite anymore. If that's the case, it could be a little headache. But if you repair surgically right away, it allows you to basically get back to physical therapy as soon as possible and do the things you love. So what I did for her was, basically look at this picture if you can, this x-ray. As you can see, there's a through and through fracture and also another fracture down here. The next picture basically shows exactly what I did for her. Basically this screw, for the two fellas in this room, it's kind of like drywall in a way. There's a broken piece, you hold it together with a screw. The plate itself, the way it actually, the function of the plate itself is to basically absorb any energy that they put. It doesn't go straight to the fracture itself, it goes to the plate. So these are very low profile. It may look very thick and very prominent, but at the end of the day, these are very, very good screws and plates. And with technology being improved every year, you're able to see a lot of faster recovery and also increased stability too. And also, remember we talked about arthritis too. There's decreased chances of future arthritis by performing an anatomic reduction, putting the fracture back into what it looked like before, so you won't have to suffer arthritis a little bit sooner than later. So, ligament and tendon injury, basically a sprain is a term that we would use for ligament injury, and strain is something that we would use for tendon and muscle injury. A lot of the times when you sprain your ankle or strain your ankle, it's your tendons and ligaments, not really your bone. So I see a lot of degeneration, tendon rupture leading to further instability. So obviously we start out conservative. If it doesn't work out, the surgical techniques that we have, this is an example of an Achilles tendon. The gentleman that I told you about who's in their mid-40s playing softball as he was rounding first base, he heard that pop in the Achilles. Primarily what we would do is make an incision, go inside, see where it is actually torn. So we would repair everything. You can actually kill two birds with one stone, because if you actually had any diseased tendon, overused and everything, so if you had a tendon issue before, And if you have a rupture, not only can we repair the rupture itself, we can also get rid of all that gunky tissue. So it is a bonus. Obviously you don't want to do this, this is a bad injury. But patients can actually get back to doing what they love as soon as 4 weeks out, 6 weeks out. I'm not just talking about the Achilles tendon itself, but other ligament and tendon issues, because it's anatomically reduced, and we feel that we reduced it nice enough to a point where you can go back to your activities. Just a literature review. I know I don't want to include too much literature in here because it's basically basic information that I'm sharing with you. But the Journal of JBJS basically in 2005 shows that an operation for an Achilles tendon is much better than non-operative treatment, showing as low as 3.5% re-rupture rate when you fix it surgically, versus not fixing it is going to be as high as 12.6% chance of re-rupturing. So there's about 4-fold higher chance of you re-rupturing if you don't fix the tendons when it's ruptured. And also there's higher patient satisfaction rate and faster return to activity. Osteochondral lesion of the talus. This is also considered as OCD. You can have this on your knee too. One of the reasons why I have these pictures of pothole is because when patients come in, they come back with their MRI results. What I tell them is that what we have is, I tell them, have you been to Chicago? They go, yeah, sure. What do you take? I-88. Okay. Have you had any potholes before recently? They go, oh yeah, of course, there's a bunch of them. So when you hit one of those potholes, you know exactly what you hit. And sometimes leading to, unfortunately, a flat tire. But when you don't hit the potholes, you never know it's there. That's exactly how it feels like. It's a small little divot inside your ankle joint. So when you hit that area, you know it's there. So day 1, day 5, day 6, day 24, it hurts. Rest of the time, you're fine. You're feeling crazy because you go, where's this pain coming from? It's because you have that divot, almost a pothole, inside your ankle joint that continues to bother you. So how do you fix this? Just like we talked about with the scope, we can go in there with the scope, ankle arthroscopy, to see the extent of the injury. If it's small enough, it's something that we can treat with the scope by allowing us to drill that bald spot to allow the blood to come from underneath. So we're basically using your own stem cells to kind of cover that area up, if the area is small enough. But if the area is big enough, just like this picture here, just an example, you see this divot here, obviously you want to fill it up. And it's not something that I can fix with a minimally invasive surgery. So what we would do is perform surgery. It's just like hair follicles. Hair restoration, same thing, cartilage restoration. So you either want to get your own cartilage or grab somebody else's, like a graft, and plug that little cartilage inside this little bald spot so you won't have that clicking pain anymore every time you walk. Nerve entrapment, basically this is a burning, tingling-like sensation. I see this a lot in the diabetic population because their sugars are overwhelming. It's very high, it causes what's called a neuropathy-like symptom, very burning and tingling sensation. As you guys see commercials for Lyrica all the time, right? So basically a lot of burning and tingling sensation can happen to your ankle joint too, due to cyst formation, scar formation. If somebody accidentally kicked you maybe a couple weeks ago, you might still have that burning, tingling sensation too because your nerve is still recovering from the previous injury. And what we would do normally, the reason why I have a picture of the hand is it's kind of like a carpal tunnel syndrome. Instead it's called tarsal tunnel syndrome. It's at the inner portion of the ankle, just like in this picture, and it is caused by varicose veins, cyst, previous injury, sometimes foot deformities too, such as flat foot, by causing less area for the nerves to breathe. So the surgical intervention that we will be able to do, make an incision and get rid of the occupying lesion or cyst, or free that area up of any scar nearby the actual nerve itself, so you will feel a lot better afterwards. Finally, ankle arthritis, there's osteoarthritis, wear and tear, post-traumatic arthritis if you had a motor vehicle incident or work-related injury, or rheumatoid arthritis or psoriatic arthritis, autoimmune disease. So a lot of times there's not a whole lot that you can do. Basically all you can do is basically buy time for you to continue with an ankle brace or consider a surgical intervention, basically because it's bone on bone. Every step that you take, significant amount of pain. There's not that cushion anymore that you had before. No wonder you're hurting that much. So some of the techniques that you have here, this x-ray compared to the previous x-ray I showed you, there is no joint space here at all. You're seeing nothing. You're basically seeing tibia to talus, which is bone on bone. Every step that you take, significant amount of pain. So some of the options that you have nowadays is ankle fusion or an ankle implant if conservative measures fail. Ankle fusion is good because it allows the pain to go away. And also it's actually good if the patient is not adequately fitted for the ankle implant, because you have to have good bone stock, you have to have a good blood flow in order for you to heal up the ankle implant procedure. So ankle implant is a very improved technology, as you can see here, just like your knee replacement, hip replacement. There has been a lot of study done recently showing that 90% 10-year survival rate, meaning that the implant itself survives inside your body for more than 10 years, and there's about 90% success rate. The reason why it is 10 years is because the studies are limited. If they actually do 50 years more worth of study, the numbers will be different, but this is what they have available today. So basically, just like your knee implant and hip replacement, same exact modality. Allows you to live life. Obviously, you can't run a marathon with this, but if you like to play with your grandkids and also continue on living your life, like to jog and go for long walks with your dog, this may not be a bad idea and a better option compared to your fusion. Finally, return to activity. Non-operation versus operation. This is kind of general in a way. I kind of want to show you guys that non-operation is not the wrong thing to do. If it's the right thing to do, we always go non-operative. It's easy on a patient, easy on the patient's body. But a lot of the times, it's more time consuming. Usually, we put the cast on a patient for about 6 to 8 weeks period, followed by, you see those big, ugly black boots that people wear, right? You're going to be on there for about good 2 to 4 weeks, depending whether you have a fracture or a tendonitis or tendon rupture. Followed by, just like I said, if the bones do not unite, there is a thing called bone stimulator, which allows the signal to go from one area to another to allow you guys to actually fix the bone a little quicker. I actually did a little fellowship out in Germany, and actually the orthopedic surgeon out there and I did a lot of surgeries on soccer players. And he used to joke with a lot of people in their 40s and 50s when they actually had some issues with bone healing, and told them to drink a lot of milk and go outside running naked to get some sun and get some calcium in your body. So I'm not telling you to go outside and run naked outside, but I'm telling you to basically, if it's going to be non-operative route and you have a fracture, it is best for you to kind of keep up with your calcium, your sunlight, and good diet. Obviously, with the operation, cast application is a lot less, about half full compared to non-operation. Transition into regular walking boot and stable shoe gear right after in physical therapy. So overall, if you choose the operation because the doctor suggests that it's best for you and it's required, it allows you to have decreased, better ankle range of motion, strength, stability, the muscle gets stronger, and you guys are satisfied overall, and you guys are able to return back to activity without much irritation. One final thing that I kind of wanted to share, this is once again another literature review. My patients in their high school, they hate to wear ankle brace. Their moms tell them to wear it at all times, but they do not. This is one of the reasons why you should. This is basically a study done showing that after a surgery, a patient was immobilized on a hard cast. And later on, they studied 2 different groups. One group that continued with an ankle brace, one group that did not continue with the ankle brace. As you can see, the re-rupture rate is about half full on patients who continue to use the ankle brace. Complication rate including adhesion, sensibility, scar tissue, infection, totaling the complication rate from 35.7% all the way down to 19.5%. So when the doctor tells you that you should be wearing an ankle brace after your injury, this is one of the reasons why. Okay? And as surgeons, I know my colleague Dr. May is here, and also others will be here as well. After surgical treatment, our goal is to basically reduce, lengthen, stabilize, and alleviate the overall symptoms. But we can't do everything on our own. Treatment cannot be complete without physical therapy. That's very, very important. I can do the best ankle fracture job in the world, but without proper physical therapy, it wouldn't be as complete. Because clinical orthopedic related research back in 1987 showed that immobilization continues to lead to muscle atrophy, osteoporosis, diminished proprioception, cartilage atrophy, and ligament effects. So back in the days when they used to put the patient on cast for about 2 months for a Achilles tear, now they're fixing it and allowing the patient to go back to physical therapy as possible as soon as 4 weeks, so that collagen fibers and also immobilization won't lead to all these problems that I have mentioned. So in summary, ankle pain is a common injury from work site, sports-related injuries. Advanced imaging studies may be necessary. Conservative treatments are available, and definitely is the first thing that you guys should do. But surgical treatment can be superior at some point. Importance of transitioning to functional brace, once again, is very important. And without our partners of physical therapists, we won't be able to actually do the surgeries that we do. So, thank you very much. I'll take any questions. This is actually a picture that we took from the gala. And this is my partner, Dr. George, Dr. Kuo, Dr. Pissinger, Dr. Komanduri. This is myself. And I thought he did a pretty darn good job until one of the guys actually mentioned that if I was to cover up my portion of the eyes, Dr. George's portion of the eyes would be about the same. Any questions at all? There's some questions now. If you have it. Yes?
I'm wondering what do you think about osteomates?
Osteomates. Well, are you taking them now for?
Yes.
Well, I'll be honest with you. With a lot of medications and nutrient-wise in regards to your arthritis, there's not a whole lot of research backing the data up in the surgical community. But I work closely with physical therapists and also primary care physicians to get the most information that I can possibly can in regards to medication therapy, because there's not a lot of treatment modalities that are out there for underlying arthritis other than injections and medication use. So I wouldn't dare tell you not to take it, but at the same time, I can't tell you enough to know that you should continue to take it. But if it continues to help you, if you believe that it's been helping you out, I don't see a reason why you shouldn't. Yeah, there you go. So,
Thank you.
any other questions? If not,
Okay.
thank you very much for your time.
Thank you.